All right. So, oh, I'm sorry. What was that, Bobby?
Oh, I just went ahead and hit record to get us going.
Oh, okay. All right. Um, all right. Well, you have met Shelley Bailey now, who is the PDAB board chair. Also joining us today is John Murray, who is a board member. And then from the PDAB staff, we have Stephen Koyman, whom you have also met. And Melissa was signed up, but I don't think I see her name. So I'm not sure if Melissa Stiles is on or not.
No, I think Melissa was signing up so that she could coordinate for other
Okay.
boards and have
Gotcha.
invites, and that would
Okay.
be consistent throughout all meetings. So
Okay. And Allison, I don't know if Jane is on or not. Jane Horvath had intended to sit in, and her name will appear. There you are. Hi, Jane. Yeah, I'm having a little trouble seeing the entire list of attendees. So I would also then like to introduce Jane Horvath of Horvath Health Policy, who is also supporting the board with this work. All right, so really before we get into today's session, I want to thank you all for attending, knowing that your time is incredibly valuable. We appreciate your willingness to share your perspectives on this important topic. So to level set on today's topic, we're going to have a brief series of prepared slides that we're going to review before we get into the discussion, and hopefully this will take about 15 minutes. And so we'd ask that you hold any questions or comments until we've completed the presentation. And then once we've completed the slide deck, we have a series of questions that we will be going through to solicit your input, generate dialogue among the group. We're not going to be able to answer specific questions related to methodology or affordability evaluations, but as Bobby mentioned, we'll have a mechanism for you if you have those types of questions that you can submit them directly to the board for consideration. And when we get to that point in the session, we're not a huge group, but we would ask that you introduce yourselves when you're speaking and speak clearly so that we can accurately capture your feedback in the notes, and ask also that you mute yourself when not speaking. We are asking attendees, even though we're a small group, to use the raise hand function to be recognized to speak, and that'll just allow us to make sure we give everybody who has an opportunity to or wants to have an opportunity to comment to do so. And then finally, we realize this is a very complex topic, and one that will likely generate a lot of feedback among the stakeholders. And so for this reason, there is a second meeting that we will use to continue the discussions and allow everybody an opportunity to share their perspectives. We have a whole series of questions that we will walk through, and we don't anticipate finishing those today. So we encourage you to attend the second session if at all possible. All right, so we'll get into the meat of the conversation. The Prescription Drug Affordability Board was established within the Department of Consumer and Business Services and is committed to protecting residents of Oregon, state and local governments, commercial and employer health plans, healthcare providers, pharmacies licensed in Oregon, and other constituent groups within the healthcare system from the high cost of prescription drugs. The board was established by the legislature under Senate Bill 844 in 2021, and later that was codified into the Oregon Revised Statutes, Section 646A.693. And again, our goal with these sessions is to get your perspectives on the use of upper payment limits or UPLs to improve drug affordability, and also gather any recommendations you have on improving drug affordability for Oregonians. And these sessions will inform the board's work on developing a plan for establishing the UPLs as required under Senate Bill 192. So a little bit on the background around the PDAB process. Through the authority that was granted by the Oregon legislature, the board is tasked with establishing a subset of drugs for review for affordability challenges within the healthcare system or for high out-of-pocket costs for patients in Oregon. And we've given the authority here on this slide. The board is currently reviewing the drugs listed on this slide and with the schedule that is given here. And I would encourage you to review the website periodically for changes to the schedule or the drugs that are currently under review. And I will note that there was a board meeting yesterday. And so if you are interested in the schedule or the drugs under review, I would really encourage you to review the website for any changes. All right, so we will talk a little bit about the landscape here. Oregon is in good company with other states who have established UPL authority, and this is an ongoing topic in other states as well. There are certainly other states that are not on this slide that have pending legislation or considering legislation around establishing some kind of a PDAB or affordability board or a UPL authority of some kind. For purposes of our conversation today, the states that have established PDABs, specifically Colorado, Minnesota, and Washington, have full authority to establish a UPL. And you can see there are other states that are starting to leverage this, such as Maryland and Maine and New Hampshire. Have taken a little bit different approaches, but they still have some authority around UPLs and PDAB establishment. I would say that Colorado is probably furthest along in this process, having initiated a rulemaking process a couple of months back around NBREL. And so that's very interesting. If you want to see the minutes, the link is below if you want to see any of the context around the conversations that have happened in Colorado, if this is a topic of interest to you. So let's talk a little bit about the Oregon specifics. In their 2022 report to the Oregon legislature, the board describes their concept for a UPL in Oregon. And specifically, it would establish a maximum amount that could be paid for prescription drugs, similar to a federal upper limit or a NADAC or a MAC price that's currently established and used in prescription drug reimbursement today. And it's not intended to set a list price, nor is it intended to impact the Medicaid-based best price calculation. And these are concepts we'll come back to in just a little bit. So this is a pretty simplistic representation of the supply chain impact. I know everyone in this audience is very familiar with the complexities of the pharmaceutical supply chain, but this slide is really intended for purposes of level setting, understanding that we have a number of different focus groups and constituent groups that we will be interacting with. So we're attempting to ensure that everybody is at a similar level of understanding around these kinds of concepts. So this slide is really just intended to illustrate the basic process for retail and health system or physician administered drugs and their associated systems of payments, rebates, and product flow. And we're going to come back to this concept in just a minute. So this the slide around potential UPL principles is adapted from work that was conducted by Jane Horvath, who, as I mentioned, is on the call today. And in principle, it's intended that UPL should improve market function for prescription drugs with a UPL by achieving one or more of the listed outcomes, such as improved access and reduced costs within the system. So coming back to the diagram we looked at a minute ago, what we're attempting to do is describe a situation in which the UPL could potentially be implemented basically here at the top of the supply chain flow. So intended to be kind of inserted in between a manufacturer and the distributor, wholesaler, direct purchaser level. Or for a little bit different way of looking at this, we also have this conceptual representation of the potential UPL model. And again, this is material adapted from work that has been conducted by Jane. And it offers a little bit different view of the concept that we presented on the prior slide. And again, we're talking about an insertion here in the supply chain. And so really what this is intended to illustrate is the progression of the UPL through various parts of the pharmaceutical supply chain, with the manufacturer agreeing to sell drugs to be used in Oregon to the wholesaler at UPL. And as you'll note on these slides, they acknowledge the options that might exist for volume-based discounts or additional discounts with large entities, et cetera. And then illustrating that the wholesaler buys at UPL minus a discount, selling at pharmacies as well at UPL minus any discount. And moving through the chain, it's intended that providers would be able to purchase at the UPL minus a discount, billing it to the insurer, the PBM, or the patient based upon UPL as well. In a PBM type environment, the insurer's PBM would reimburse the pharmacy at UPL less any discounts and bill insurers at the amount reimbursed to the pharmacy. And finally, the insurer is billed by the PBM for prescription claims that are paid at the amount, as I mentioned, reimbursed to the pharmacy. With all of these considerations being at a maximum of UPL, and as we noted earlier, the UPL replaces or is intended to replace the WAC, the AWP, AAC, that sort of thing as a metric for financial transactions. So as we were preparing these slides and discussing this, internally and with the PDAB staff, we felt like there were some recent industry events that might provide a little bit of a guide as to how a UPL might work in the marketplace. I know everybody on this particular call is very familiar with the recent change, or at least the impacts of that change, to the federal Medicaid drug rebate program. And the rule changes that went into effect on January 1st had an impact on the rebate rates that would be paid by manufacturers to the Medicaid drug rebate program. And in some cases, it was a pretty significant, or would have been a pretty significant change. And in response, the manufacturers for certain highly rebated drugs in the Medicaid space implemented reductions in WAC for these drugs. And so we want to encourage people to keep this concept in mind as we move into the interactive section and consider whether this might be an opportunity to think how it may have worked through the supply chain as well. A couple of examples on the slide were, for example, Advair discus and some insulins that could serve as an analogy for how a UPL might similarly impact the supply chain. Okay. So many of you participated in the survey that was provided in advance of these sessions, and we truly, truly appreciate these responses. We got some very, very thoughtful responses back, and we appreciate that feedback. And we're going to explore some of those same questions and some different ones now in our session. And again, appreciate your feedback and comments. And as a reminder, please remain on mute unless you're commenting. State your name and organization for us so we can capture it. And then we mentioned that the further comment or feedback can be provided. You can either send it to the Oregon PDAB at mslc.com if you have something specific to the focus group discussions or survey concepts that you want to provide to us. And we would like to get that feedback by June the 4th. There is also an option. This is the process on the board's particular website. You can participate directly in the public comment process by writing and submitting a letter to the board or signing up to speak during board meetings. And they do have a participation form that you can find at this particular location. All right. So
we're ready to jump in?
I think we're ready to jump in.
Great. Well, Linda and I are going to sort of tag team this conversation with everyone, and we really hope it's interactive, and that you feel comfortable sharing the specific feedback that we can then take and sort of pull everything together for the board's consideration. And what we've done is we've kind of grouped our discussion into a few different, I'll call them buckets or focus group areas for questions. The first being kind of the impact of drug affordability overall. Just to kind of level set a little bit, and as Linda said, some of these questions are going to be somewhat similar to the survey, but some nuance, and we've tried to take some of the survey feedback and inform this discussion as well. But for purposes of just kind of getting started and having this discussion around the impact of affordability, I think for purposes of level setting, we'd love to hear from you kind of when you think about drug costs today, what does affordability mean to your organization? I think what we want to do is kind of come to some common understanding of how that term might be used. So really anyone can jump in. Again, I think what we'd like to know first off is, what does affordability mean to your organization? And if you're speaking, you may be on mute. No one has a thought on what affordability means to you. Okay. Well, let's move on. Maybe we can get a little more detailed. To the extent that you believe drugs generally or specific drugs are unaffordable, what specific challenges does that present to your organization?
Will you repeat that question, please?
Sure. Again, to the extent that you believe drugs or specific drugs, and feel free to comment on that if that's the case, but to the extent that you feel as drugs are unaffordable, what specific challenges does that present to your organization? Could be in terms of, specific financial challenges, could be in terms of, access issues. Again, we think that these answers are going to be, maybe unique to the constituents that we're discussing this with. Really trying to understand what affordability means to you as a constituent group.
Are these questions specifically for community pharmacies, or are they just being used for all of your surveys?
Generally speaking, a lot of these questions are general and would be applicable, but we are really looking for your input from your perspective. The idea here is to be able to take feedback from each of the constituent groups, be able to present them to the board as, again, as specific to your group so that they can understand, the various stakeholder perspectives.
Okay, I'll go ahead and jump in. Brian Mayo, Executive Director for the Oregon State Pharmacy Association. Our primary concern is making sure that pharmacies aren't stuck with the upper payment limits when they're purchasing the drug and then being stuck with the extra cost. Based on your scenario that you put in here, it looks like you're trying to pass along to the manufacturers, but we know that there are ways that pharmacies tend to get stuck with extra payments and those types of reimbursement issues. So the pharmacies have to be protected. They're already going out of business too fast and need to stay open.
So Brian, is there any way you want to elaborate on, certainly I think we understand the PBM issues or some of the ways that pharmacies might be, as you say, stuck. Is there anything that we might not be thinking of in terms of the concerns about the pharmacy, or how they might get stuck with the higher rate that you want to share?
I mean, pharmacies right now are in a position where they are stuck with the bill, whether that's
Okay.
a lot of times from the insurers and the PBMs, and you know, they're already getting reimbursed underwater, so
Okay.
they're struggling to stay open. So I
Okay.
see that Kevin has his hand open and could probably talk a little bit more about the details when it comes to it. But yeah, but our concern is making sure that the pharmacies are not stuck with the extra payments.
Gotcha. Okay, thank you.
Go ahead, Kevin.
Yeah, I mean, I think the concern is that, pharmacy contracts are based off of either a MAC from a PBM or like an AWP minus scenario. There's not any language in there that would anticipate anything like an upper price limit. And so it really kind of becomes really up to the PBM, because they control the contract, how they're going to interpret reimbursement under that scenario. So they may just say, okay, well, upper price limit is this. The state has said this is what this is, so that's what we're going to pay you. So we're going to give you zero markup on those medicines to dispense them, right? So that's a possibility. And since there's really no precedent on this or regulation, they can kind of do what they want. And that presents a problem not only for the pharmacy, but the patient access to the medication. Because if they decide not to pay me what my price is to dispense the medicine, then how can I afford to make it available to a patient, right? So that's the main concern, I think.
That's a great answer, and I think that's that's really what we want to, I think, get to, right? Is what are the specific pain points, that administratively, financially, that you're going to feel, so that we can capture them. So looking at the list, Michael, I think you had your hand up first. If you'd like to go next.
Yeah, thanks, Bobby. This is Michael Murphy from the American Pharmacists Association. Just want to share that we agree with the points that Brian Mayo had shared about some of the concerns, largely that we believe that these are unintended consequences that might come from not having explicit protections for the pharmacist's acquisition cost of the medications, as well as their dispensing fees, that could potentially lead to pharmacists unintentionally getting squeezed in the middle of this type of policy being implemented, and we would see further erosion of the pharmacy business model that could just lead to less pharmacies being available, less medications being accessible to patients. So just want to highlight those concerns as well.
To dig into that a little bit further, and I certainly take your point, the concern about the unintended consequences if implemented incorrectly. Do you have ideas for how, ideas or recommendations for how it could be implemented to avoid or mitigate some of those unintended consequences?
Yeah, I would be curious to hear from Brian Mayo and some Oregon folks, but I think that any ability for the PDAB to include explicit protections to prevent those potential unintended consequences would be one way to potentially mitigate that and to resolve some of these concerns.
Do others have, just to kind of build on that a little bit, do others have around the implementation question and attempting to mitigate some of those unintended consequences before we move on? Do others have thoughts on that?
It looks like Ken had some comments.
Well, yeah, Ken Zintera with BH.
Oh, that was Ken. Yeah.
Yeah. I'm Ken Zantara, president of BHS Pharmacy. We're closed door long-term care in Eugene. And you made the comment, I was just going to add on, you made the comment that this is similar to what happened with the Medicaid rebate rule and that the WACs decreased in response to that Medicaid rebate rule. I'm not sure I know a lot of people were aware of this, but across the country, this has really, really whacked our gross profit and really took a bite out of our ability to, like Brian said, stay in business. I see this as just one more nail like in that coffin. I'm not going to get in, the IRA is coming as well. That's a similar situation. All these things they're going to do, if we don't have any protections, are just going to continue to decrease the gross profit, our operating expense, and we're not going to be around. And that's my real concern, is that it's great that we're setting a UPL and trying to make drugs more affordable, but if there's no access, yeah, I don't see the point, really. I understand that the legislature passed this and all that, and we have a duty to do this, but that's all.
Okay. And Amy?
Hi, yes, Amy Servan, Director of Pharmacy at Road Community Health, and I think I'm coming at it a little bit different perspective than just community pharmacy in general. We're a 340B pharmacy in-house in a FQHC. And I'm still trying to kind of wrap my head around all this, so I'll apologize that I'm still kind of learning, but I am curious how this is going to impact our 340B savings. And when we talk about affordability and accessibility, when we're looking at those shrinking savings coming back in, we're looking at not being able to offer a lot of the services that our 340B savings, not just drug availability, but our community health workers, our clinical services, a lot of things that are offering access to patients that can't afford medications, we're utilizing those savings for. And when we're seeing these shrinking numbers and as other people have said, no protections to that from the PBMs and everything else for reimbursements, I'm very concerned at what implications this is going to have for accessibility to our patients and our particular populations as well.
That's a great comment, Amy. I'm curious to dig in a little bit more too. When you say, and I think I understand what you're saying, that the savings generated, you're leveraging those for additional community-based services through the clinic. Are there specific services that, from your perspective, would be most impacted?
Well, yes, like right now, we're able to utilize some of our savings and our prices. With the IRA, we're now looking at having to offer it at upwards of $30 and $40, which is impacting patients that couldn't afford it to begin with. So just drug affordability, even at a 340B level, is impacted. We utilize our savings and we put it back into our community health center. We have food pantries that we're able to help facilitate. We have community health workers and kind of those services that are non-revenue generating. We're able to kind of do some of those services through our community health center with our 340B savings. Clinical services and clinical pharmacists, when billing's not necessarily applicable we're able to do that. Behavioral health, helping to open up dental services before they're revenue generating. Those are all things that those savings go back into our community health center. And those are generated from those 340B savings and the affordability of those medications and the cost differences for us and reimbursement.
And one more thing, just to kind of dig in a little bit further too, where are you located in the state? I'm just kind of curious to get some perspective, kind of geographic.
Sure. Our particular community health centers are in Southern Oregon. So we're Jackson County, Medford, Butte Falls, and a lot of the rural areas down here.
And I suspect, I don't want to put words in your mouth, so I'll ask that, in talking with your colleagues, I mean, do you feel like that's a common perspective, or is it kind of unique to your geographic area? Just kind of curious.
It is every single 340B pharmacy FQHC leader that I have spoken to across the board.
Thank you. It's like, Brian, if you have a comment.
Yeah, I have one other thought about this process. I'm also concerned that the PBMs are, they have a history of doing steering and forcing people to go use their pharmacies and also do mail order. I'm concerned that the PBMs are going to force people to fill the drugs at out-of-state pharmacies to avoid the per payment limit. So that's obviously going to be loss of revenue for the pharmacies and then also loss of access for the patients.
Great comment. Any other thoughts on, again, this kind of direct impact, the meaning of affordability and direct impact to your organization before we move on? Linda, any other specific questions on this? I think we kind of hit our next one in some of the comments that we had, so we can probably kind of move on to the next broader topic.
Okay, I agree.
Awesome. So next kind of general bucket of questions or topic of conversation that we wanted to dig into is kind of what you all see from your perspective, the desired state of drug affordability. I know that's a pretty broad kind of bucket, so to speak, but what we're really looking for is, specific outcomes that would be needed for you to consider, a drug affordability or upper payment limit successful. I know we've talked about, mitigating the impacts to, the unintended consequences, ensuring access, things like that. But I'm curious, are there other outcomes that you would see, that need to be taken into consideration in order for this UPL program to be successful? And this could be in terms of implementation. It could be in terms of, the model itself. I think we're really looking for any feedback that you have on these questions. Yeah, Kevin.
Yeah, sorry, I didn't identify where I'm from before. Kevin Russell, I'm with Nullco Advisory. We're a consulting company that advises various types of pharmacies. I would say that, desired state of drug affordability is we want to make sure that we're accomplishing the goal of increasing access to the patients, right? I think that's a key piece, and I think there are potentially unintended consequences of this. So we're already seeing in the marketplace where in the biosimilar marketplace is a good example where there's much more affordable a product coming to market, and patients are not getting access to that drug or those prices because the people controlling their benefit are instead opting for a higher rebate drug so that they can maintain their margins on that drug, but the patient may still be paying more. So there's always the option here of, people moving away from some of these drugs on a formulary type of basis that we need to guard against. But then we also have to kind of look at the impact of patient assistance programs and, copay assistance and, those type of things. And will these prescriptions still be eligible for those types of situations? Because if a patient is paying $0 today and getting the medicine, which is often the case with some of these medicines because they're on patient assistance, and then we create this, upper price limit where there's this discount and the manufacturer says, okay, well, in Oregon, we can no longer afford to do patient assistance programs because we're writing this discount, right? Now all of a sudden we've created a problem of affordability where there wasn't one before because they have these programs. So I think, some of those complexities need to be taken into consideration.
Great comment.
So, Bobby, do we want to kind of move into the desired state? Because Kevin's actually made excellent points, and they're kind of covered in some of the questions we were going to move into around impact.
Yeah, go for it.
Yeah. So, Kevin, we anticipated some thoughts along that line, probably driven partly by the survey responses. And so you've mentioned some of these challenges. and benefit design. You talked a little bit about the high cost, biosimilars, the high rebate biosimilars, and concerns about patient cost sharing. Do you think there might be other changes in benefit design or utilization management that could be prompted by this, or is it really more? Are you really more concerned about the benefit design in terms of the rebate impact and patients paying for example, the higher copay and due to the choice of drug? For example, would this maybe be a similar situation where a drug with a UPL, if it has some kind of competitor, might be perceived as less favorable to in terms of access to the patient, if that made sense? Oh, yeah, go ahead. Absolutely, Kevin.
I would say that it could really be a mixed bag. I think we could definitely see some benefits of this for sure, where they move to formulary, they reduce the formulary tier status of these drugs for patients to make them more affordable, so that people will use a lower cost drug. So I think there's certainly potential for positive impact, which will improve affordability for patients, as well as costs to a health plan or an employer that can be passed through. And I think, if we do this, we'll find out exactly what choices they make. And it's kind of like what we didn't know about biosimilars and these low prices. What are plans going to do? And we've seen the results of that. They're all over the board. Some of them say, yes, we're going to move to the lowest price biosimilar, and we're going to make that a lower tier for our patient and make it available. Others have said, no, we're going to keep the branded product, and because rebates are more important to our client, right? And sometimes they pass that savings on to the patient, sometimes they don't. So I think we're going to see it kind of all over the board.
Okay. And not really not to speak for the board, but is this something you think they should try to address? And I don't know that is even an option or an opportunity, but is that just another thing that it feels like is a concern that needs to be addressed somehow?
Yeah, I think if it's possible to write a rule that says that any savings from the upper price limit needs to be passed on to the patient, right? That would certainly be something to have in there. I don't see a scenario where they make the patient pay more, but I will say that you don't always anticipate how things worked out before either. So, but some sort of protection of that would be probably helpful.
Okay.
Do others
Hello.
have the same question? Go ahead. Sorry.
I'm sorry. My name is John Murray. I'm a PDAB board member, and I'm also a pharmacist with pharmacies in rural Oregon. And I guess my question or concern as a board member and pharmacist as well, my perspective, of course, is from community pharmacy. But as a board member, we have seen, as a pharmacist for the last 30 plus years, we've seen attempts to improve the system, drug delivery system, to benefit all aspects, but primarily the patient. That we've also seen maneuvering around, and so whether we do something in the legislature or we put rules in place or we try to, there's a lot of maneuvering in the marketplace that comes about that often thwarts that. My concern is, and you're noticing it in the wariness of pharmacy in general, pharmacy, whether you're a pharmacist or you're representing pharmacists, that unfortunately, that's our history. We've been maneuvered around just about every time. And so when we talk about the worries that we have of the program going into place, myself as a board member, what capabilities will I have to comment as just one board member, of course, on the PDAB board to implement these protections? What has been seen, for example, in other states? What capability will I have to suggest this particular caution or this particular rule? Please.
Mr. Murray, thank you for sharing that with the group today. I would say that's probably a little bit out of the scope of what Myers and Stauffer's is doing for these listening sessions, but I've certainly written it down for us to talk about in our board meetings themselves about, I guess, since they did solicit suggestions from the stakeholders here today, right? If in a perfect world, what would be suggestions that you would make to the board? So I certainly heard the suggestion that you shared, which is just kind of clarity on what we are able to suggest as independent people on the board. So certainly thank you for sharing that. I don't feel that Myers and Stauffer's probably has an answer for us related to that today, but we can certainly document that for the notes that will be distributed to the larger board. So thank you very much for sharing that.
Any other comments on this set of questions? Particularly in terms of access, some of those specific challenges, changes in benefit design, strategies, et cetera. We move on to the next question. As Linda said, some of these have been kind of built, some of these questions are kind of building on feedback that we received from the survey, which if you haven't had an opportunity to respond to, please do. Mm-hmm. But some of the respondents had indicated that there was a concern that the UPL would be challenging to implement, just specifically because of the operational challenges and some of those things I think we've talked about around what members or payers in other states. I think that it may have been Brian or Kevin who had kind of touched on this earlier, but in terms of that particular issue, what are some of those challenges that you perceive? Again, similar to what Linda asked, are there things that the board could do or consider in eliminating some of those challenges as they implement this policy? Go ahead, Kevin.
Sorry, me again.
No.
Submit some written comments about this. I do anticipate some issues here where, for example, how do you submit a claim for? Usually you submit like a usual and customary price, right? Mm-hmm. So in this case, you have to submit something different than what you're submitting today, which means you'll have to set up some sort of a unique, drug-specific payment thing in your system to send to a PBM for payment. And the PBM may not recognize that how you're sending it to them because it's not normal or customary, or the PBM may decide in their contract for Oregon that's like, okay, this is how we're going to send upper price limits, right? You're going to submit it this way to us. But then another PBM may say, no, you're going to submit it this way to us. And now all of a sudden I have to know to program my computer differently for two different PBMs, which is not really workable when there's 30 of them, right? So, so I think that's a potential issue that would need to be sorted out. And if there was some sort of standardization in that process, that would be helpful.
Okay. Kevin, do you think the compendia could have a role to play in something like this?
The compendia?
Hmm.
I'm sorry, what do you mean by?
Well, like a First Data Bank or a Medispan, some one of the pricing compendia.
Sure. I mean, they certainly could play a role in something like this, because people look to some of those for those agencies for how they transmit data today.
Hmm.
But I would say that's one of the things that would be helpful to, maybe try to, negotiate or talk about a standardization process ahead of time, in anticipation of implementation.
I think that's a great comment, and it sort of leads me to ask, what other I'll think of them just sort of administrative complexities, right? From your perspective, I mean, this is a really great, what you had just said was a really great point. But what other types of administrative complexities like that would you see from your perspective that would make it challenging to implement?
I think another piece is that if all of the, I've audited quite a few pharmacies and PBM contracts, and I'd say the average pharmacy probably has 30 different agreements.
Mhm.
All of those will somehow have to be amended.
Mhm.
And so the time spent in that
Sure.
process, and the fact that the communication is sometimes extremely difficult with the PBMs, or it's only one-way communication. That's quite an administrative burden. As an administrator, I'm thinking about this going, man, this is going to take months and hours of time to work with these payers on, and I'm not going to get paid for that.
Right.
Right? So, and PSAOs will need to get involved, and some of the pharmacy service organizations, and they're national, so they're going to have to do one-offs for Oregon, and is that really a priority for them? So I think it gets pretty complex.
Mhm. Kevin, you alluded to it a little bit about the time. I was going to ask you specifically what might be the time frame that would be required to, for example, what kind of lead time do you think this would need? Obviously, it's not 3 months, probably not 6 months, a year, 2 years, 18 months. What's practical?
Yeah, I would say that you probably need at least 6 months for vendors and people to implement the changes necessary in software and things like that to be able to administer these things properly. From a PBM perspective, that can take longer because some of them will, they're on annual cycles for how they review things and deal with things. And granted, if rules are written that they have to comply with, and hopefully they will, comply sooner. But just to give you a heads up and to name names, CVS Caremark says they require 3 to 6 months to review a contract change. That's their lead time to start that process. And a recent negotiation took a year and a half. So, I mean, that's kind of what we're up against.
Okay, that's helpful. Thank you.
Do others have thoughts? I know we're getting close to one on that particular issue in terms of the administrative complexity or administrative burden. Do others have thoughts on that before we move on? Okay. I think we've maybe got time for maybe one or two more questions before we have to kind of push pause until our next call. But, again, building off of some of the feedback from the survey, some of the respondents had indicated that the UPL could actually create opportunities for a positive impact on patient access. If folks on the call have similar thoughts, I'd be curious to hear, what you think some of those positive impacts might be.
I know we did talk a moment earlier about the potential positive impact being perhaps an opportunity for a drug to end up on a lower tier and there to be some cost savings. So I know that was certainly one you all mentioned. But were there other things that you think might be a positive around this?
Well, Linda, you know, the transparency is sort of where we're starting to go next, and that's a big, I mean, from my perspective, I think is a big discussion, and I suspect folks will have thoughts on it, particularly some of the comments that have already been made. So I don't know if it makes sense, you know, to give folks a couple minutes back, and then, you know, we'll pick up right there on our next call, and if that makes sense to you.
Yeah, it does. I actually was kind of thinking the same thing. So transparency being something we want to explore. We touched a little bit on the challenges around patients or PBMs or providers who are out of state. So maybe another topic we should talk a little bit more about the next time. Give you an opportunity to think about what some of those impacts, challenges, concerns, and maybe even opportunities might be around those topics. And then certainly one of the other questions we're going to want to ask you is what other strategies the PDAB might want to consider in addition to the UPL. So we'll give you a few minutes in a week or two to think about those things, and we'll certainly talk about those. Want to explore those next time.
Perfect. And as we said at the beginning, you know, the links here, if you want to provide some feedback offline, feel free to shoot us an email at the mslc.com address there. And then again, as Linda pointed out at the beginning, you know, any sort of broader commentary or feedback through the public comment process available through the PDAB website. So,
and I did pop those that information into the chat too, so that you would have the actual clickable links if you wanted to.
Perfect. Okay, well, I think we will wrap it up here for today. Thank everyone for their participation. We really hope to see you again on the next call, and encourage you to include any of your colleagues. Okay.
Yep.
Shelley,
and again, encourage you to take the survey if you haven't, or encourage your colleagues to take it if they have not provided feedback.
Shelley, I know she came off mute. Did you have anything you wanted to close with, or?
I didn't have anything to add. I just was going to say goodbye to everyone on the call when the call wrapped.
Okay, great. Well, thank you so much.
All right, thanks everyone.
Thanks everyone.
Thank you, everyone.